Good morning, everyone. It is my pleasure to introduce my dear friend, Dr. Katrina Collins. I have known Katrina for a while. We were co-fellows, and I will give an introduction of her. So Dr. Katrina Collins is a staff pathologist practicing at Indiana University in Indianapolis, Indiana. There she does general anatomic pathology with a focus in genitourinary pathology. She's also the Associate Program Director for the Genitourinary Pathology Fellowship. Dr. Collins serves as a Student Affairs and Research Committees, co-leads Anatomic Pathology Junior Faculty Peer Mentorship Program, and actively contributes to committees such as the Grand Rounds Planning Committee and Biorepository Steering Committee at the University of Indiana. Beyond her institutional roles, she's also a proactive member of professional organizations such as the International Society of Urological Pathology and Indiana Association of Pathologists, where she assumes the role of social media editor and takes charge of managing and hosting their online platforms. Dr. Collins is active within the College of American Pathologists, the United States and Canadian Academy of Pathology, and her state pathology and medical societies. Dr. Collins was selected for the American Society for Clinical Pathology 2022 40 Under 40 and Pathologist Magazine 2019 Power List. In 2022, she was also nominated for the Early Career Achievement Award. So with this, I welcome you, Dr. Collins, and thank you for being here.
Hi, thanks, Deanna, for that warm welcome. And thanks, Amy, for helping to coordinate this today. So today, I guess I'll just get started. I'm going to talk about the most recent 5th edition of the WHO classification and what's happened since the 4th edition published in 2016. I have no disclosures. So tumor classification is always a dynamic process. With continuous addition of new knowledge, integrating novel molecular genomic discoveries, and morphologic reappraisal of disease entities. In the 5th edition of the WHO classification, building on the 4th edition, published in 2016, there have been significant advances and emphasis on molecularly defined tumor entities as well as genetic tumor syndromes. The application of molecular profiling has made a substantial impact on tumor classification, especially in renal cell carcinomas, and with emerging promise for other urologic malignancies. Special attention has been given to grading heterogeneous lesions, inverted tumors, substaging, and new molecular taxonomy and bladder tumor classification. The current model of classifying tumors of the penis and scrotum essentially follows the previous editions with further stratification of these lesions into HPV-dependent and HPV-independent tumors because of its prognostic implications, and metastatic hematolymphoid, mesenchymal, melanocytic, soft tissue, and neuroendocrine tumors are collectively discussed in separate chapters. So I'm going to start with kidney tumors, as this is probably the area of GU pathology that's seen the most developments in recent years, and it can be overwhelming for people who don't really practice this specialty every day. So starting with kidney, there are specific new names and new tumor entities to give you a bird's eye view of just how many new entities there are. This is a list of them here and where they fall with respect to classification. I'm going to try and go over some of the more recent advances. I'm not going to be able to review all the kidney tumors, but instead it's going to be kind of a review for what's been learned in the past or in the last 3 to 5 years. So despite considerable advances in the molecular characterization, morphology remains the foundation for this classification. Renal tumors have been stratified based on the predominant morphologic subtype, cytoplasmic and architectural alterations, tumor location, correlations with the background renal disease, resemblance to embryological tissues, or a specific molecular profile. From a traditional point of view, the classification of the renal tumors has been accordingly to the main histologic feature. So the presence of clear cells defined clear cell renal cell carcinoma, or the presence of papillary features indicated papillary renal cell carcinoma, or according to the genetic basis, the presence of hereditary leiomyomatosis and renal cell carcinoma. So in the last decade, we try to find a strong correlation between genotype and phenotype. So looking for 3P loss in clear cell renal cell carcinoma or gain of chromosomes 7 and 17 in papillary renal cell carcinoma, or loss of multiple chromosomes in chromophobe renal cell carcinoma. But we realize there's some difficulties because there are a lot of renal tumors with clear cells, and it's not possible to look for molecular alteration according to the presence of clear cells. There are a lot of kidney tumors with papillary features, and also renal tumors with pink cells. So the morphology is not enough in order to identify the molecular phenotype that would correlate with the phenotype. So I'll start with the concept of molecularly defined renal tumors and share a few case examples. The molecularly defined renal cell carcinomas include TFE3 rearranged renal cell carcinoma, ALK rearranged RCC, TFEB rearranged, and TFEB amplified renal cell carcinoma, ELOC, formerly TCEB1 mutated RCC, and SMARCB1 or INI1 deficient renal medullary carcinoma. The classification has evolved in the current iteration with some new entities added, including eosinophilic solid and cystic renal cell carcinoma, again, ELOC mutated RCC, and SMARCB1 deficient renal medullary carcinoma. ELOC mutated RCC, formerly TCEB1 RCC, is a subset of clear cell renal cell carcinoma. It expresses carbonic anhydrase 9 and displaying thick fibromuscular bands trisecting across the tumor with clear cell cytology and voluminous cytoplasm. These neoplasms harbor hotspot mutations in the ELOC gene. Although initial data suggested these tumors to be non-aggressive, there have been a few published recent reports of aggressive tumor behavior. Hereditary leiomyomatosis and RCC syndrome-associated RCC is incorporated under the FH deficient renal cell carcinoma category, which now includes some sporadic tumors. Hereditary leiomyomatosis and RCC syndrome-associated RCC or FH deficient RCC are highly aggressive tumors. Even a small-sized tumor can metastasize early, frequently to the regional lymph nodes. They usually occur in people affected by an autosomal dominant tumor syndrome associated with germline mutations in the FH gene. Patients commonly exhibit cutaneous leiomyomas, uterine leiomyomas in females, and seldom leiomyosarcomas. 30% of the patients can also present with papillary renal cell carcinoma morphology. ALK rearranged RCC, which is included in the emerging RCC category in the 4th edition, is now included as a distinct entity. These are usually solitary tumors occurring in sporadic setting with a slight male predominance and have been described to occur in a wide age range, including adolescence. These tumors exhibit variable morphology mimicking renal medullary carcinoma and collecting duct carcinoma. So IHC expression for ALK antibody and FISH analysis for ALK rearrangement are required for diagnosis. ALK IHC screening has been suggested for unclassifiable RCCs with heterogeneous features as well. Targeted therapy using ALK inhibitors is proven effective and tolerable. So here's an example of ELOC mutated RCC. These neoplasms have nodular appearance at low power, created by these thick transecting fibromuscular bands. The neoplastic cells are consistently immunoreactive for CK7 with labeling that ranges from patchy to diffuse. Carbonic anhydrase 9, typically in a complete membranous fashion, and CD10. High molecular weight cytokeratin marker 34 beta E12 is usually negative or very focal. This tumor can only be classified by demonstration of mutation of the ELOC gene. While not always possible to perform this analysis, we should pay attention to this and be careful to separate this entity from clear cell renal cell carcinoma. The majority, roughly greater than 90%, have occurred in male patients with a median age of 60 years. These neoplasms typically are small, PT1, and well-delineated renal tumors. Histologically, these tumors are similar to conventional clear cell renal cell carcinoma, but contain thick traversing fibromuscular bands transecting the tumor parenchyma, giving it a multinodular appearance. ELOC mutated RCCs overlap morphologically with a subset of RCCs associated with mutations in genes in the mTOR pathway. Some have grouped these neoplasms together as renal cell carcinoma with leiomyomatous stroma. A definitive diagnosis, again, requires molecular studies confirming mutation of TCEB1 gene and loss of heterozygosity at 8q21 or monosomy 8. Without molecular confirmation, we can reasonably refer to the neoplasms meeting morphologic criteria as clear cell renal cell carcinomas with prominent fibromuscular septations and CK7 positivity, and then give a differential diagnosis. And here's an example of an aggressive appearing tumor, not only based on morphology, but also there was lymph node metastasis in this case. By immunohistochemistry, the tumor was negative for melanocytic markers, CD10 negative, and the tumors all showed retained expression for INI1, FH, and SDH. And the tumor seemed unclassifiable according to the previous tumor classification. But ALK was performed and supported by FISH analysis, which demonstrated ALK gene rearrangement, and this was classified as ALK rearranged RCC. There have been approximately 50 reported cases with nearly equal sex distribution. The patients have been both children and adults. They range from 3 to 85 years. Most of the tumors reported have been small and organ confined, so at presentation PT1, with a solid to solid cystic appearance and variegated cut surface. The 4 well-characterized cases with a VCL ALK gene fusion are distinctive in that they affected young patients with sickle cell trait and have a distinctive morphology. These neoplasms are typically well circumscribed and they may have chronic inflammation at their periphery. They are composed of polygonal neoplastic cells with abundant eosinophilic cytoplasm and often striking vacuolization. Sickle-shaped erythrocytes are more readily seen in extravasated blood than in the blood vessels. These neoplasms have been proposed to be the 8th sickle cell nephropathy. ALK rearranged RCC with fusion partners other than VCL include TPM3, EML4, STRN, and HOOK1, and are more heterogeneous. They may show cytoplasmic vacuolization, but often they have papillary or cribriform architecture and a mucinous stroma. Intracytoplasmic mucin, scattered psammoma bodies, and rhabdoid morphology can also be seen. Variant morphology resembling metanephric adenoma or mucinous tubular and spindle cell carcinoma has also been reported. Immunochemistry for ALK protein is a useful screening test for ALK rearranged RCC. TFE3 immunoreactivity is frequently seen, but the TFE3 gene rearrangement is not present. INI1, which is typically lost in renal medullary carcinoma that affect patients with sickle cell trait, it's retained. Many times we should think that the identification of a molecular alteration can be a basis for the future of a targeted therapy in the renal tumor, as shown here in this relatively recent paper. The 3 patients with metastatic papillary RCC who had progressed on previous therapies included tyrosine kinase inhibitors were treated with a specific ALK kinase inhibitor. So patient 1 had both the papillary RCC and clear cell RCC and responded after progression on multiple therapies. Patient 2, initially treated with a different drug, also responded and showed clinical improvement. And patient 3, initially suspected of having lung primary cancer, responded after an EML4 ALK translocation was identified. So these cases represent the first report of ALK inhibitor activity in metastatic papillary RCC. The morphologic data still remains of clinical relevance in treatment. There are some morphologic findings such as the sarcomatoid differentiation and renal cell carcinoma. That's the basis for specific immunotherapy. And this is very important to consider when selecting the right therapy for the patient. But again, as I said, while morphologic features are the cornerstone and important, we are moving into a molecularly defined era for kidney tumors. When there are morphologic features that are not clear and the differential diagnosis requires molecular analysis, this may sometimes be helpful in directing therapy options. And not every center will have accessibility to this testing, and it has been suggested that these cases be referred to tertiary centers where there's a high throughput of these type of cases. I'm just going to switch gears now. The increase in the novelties in the renal pathology has changed, as well as the classification of some tumors. In the previous classification, both in 2004 and 2016, in the chapter papillary renal cell carcinoma, there were two types. So type 1 was characterized by small cells with low-grade appearance and presence of histiocytes. Type 2 papillary renal cell carcinoma was described as a high-grade tumor with pink cells and high nuclear grade. Subclassification of papillary renal cell carcinomas in type 1 and type 2 is no longer recommended in the current edition, given the recognition of frequent mixed tumor phenotypes and the existence of entities with different molecular backgrounds within the type 2 papillary renal cell carcinoma category. Many evolving entities such as biphasic squamoid alveolar RCC, Wharton-like papillary RCC, and biphasic hyalinizing pseudomonas RCC are included as part of the papillary renal cell carcinoma continuum. But if we look at the diagnosis of the past and reevaluate some papillary type 2 renal cell carcinomas, we observe with the help of molecular testing and the use of specific IHC that some of these tumors that have been diagnosed in the past as papillary RCC type 2 are different entities, such as FH deficient RCC or RCC with TFEB amplification or eosinophilic solid cystic RCC. So with this improved knowledge, the suggestion was to avoid the division between type 1 and type 2 papillary RCC and to identify the papillary renal cell carcinoma with the classic morphology and to try and recognize in other tumors with papillary features, if it's possible, to identify some peculiar molecular alteration that may allow us to correctly define the tumors. And then with respect to another entity that had a name change is clear cell papillary renal cell tumor. This tumor is characterized by strong expression of CK7 and CK34 beta E12, cup-like staining pattern of CA9, and negative expression for CD10 and Amicar. Importantly, this tumor lacks chromosome 3p loss and alteration for VHL, characteristic of clear cell renal cell carcinoma, and no mutations in TSC1, TSC2, mTOR, or ELOC, all characteristic of renal cell carcinomas with fibromyomatosis or leiomyomatous stroma have been reported. This tumor is not a new entity with respect to the previous classification, but just a name change from carcinoma to tumor, because now we've collected a large number of cases in the literature. And until recently, there were no reports of metastatic events for these indolent tumors. But there are a few cases surfacing and causing concern for GU pathologists. Maybe it will get renamed once again. One proposal was clear cell papillary renal neoplasm with low malignant potential. But regardless, it's important to recognize and assign the right diagnosis versus other tumors that carry a different prognosis. Another new tumor subgroup included in the current WHO is the oncocytic tumors of the kidney. These are a heterogeneous group of low-grade oncocytic tumors currently not classifiable as either oncocytoma or chromophobe RCC. This tumor category includes low-grade oncocytic tumor, eosinophilic and vacuolated tumor, hybrid oncocytic tumor, the Birt-Hogg-Dubé syndrome-related tumor, and oncocytic renal neoplasms of low malignant potential. There are no reports of aggressive features, but again, more data is really needed for the future. At the present, the main job for the pathologist is to rule out the oncocytoma and chromophobe RCC, as well as other aggressive entities, including high-grade unclassified RCC and other malignant tumors. Here are a few examples from this subcategory of renal tumors. EVT is categorized by a solid growth of eosinophilic cells with cytoplasmic vacuolization, prominent nucleoli, and only very focal, if any, CK7 expression. Whereas lots is a neoplasm with bland low-grade nuclei, diffuse strong CK7 labeling, and negative CD117 labeling. Low-grade oncocytic tumor is composed of tumors with bland nuclei, again, diffuse strong CK7 immunoactivity, and negative CD117 labeling. Eosinophilic solid and cystic RCC, an emerging renal tumor entity in the 2016 WHO classification, has now been included in the current classification, usually described as a sporadic, solitary, and small neoplasm with an indolent course. These tumors commonly occur in young females. Few cases have also been described in males. A subset of patients with tubulosclerosis complex can harbor this tumor. Characteristic morphologic features of this tumor include a solid and cystic architecture, voluminous eosinophilic cytoplasm, granular cytoplasmic stippling, and CK20 positivity. These tumors often harbor somatic tubulosclerosis gene mutations with recurring chromosomal copy number gains and losses. And ongoing clinical trials targeting the mTOR pathway are promising. Again, further work is really needed to fully characterize these entities. This is just a summary of changes between the 4th and 5th WHO classification of kidney tumors, including those with specific names and new tumor entities. These are emerging entities in the classification from 2022. Papillary renal neoplasm with reverse polarity is a new distinct category recognized as a subtype of papillary renal cell carcinoma. These are very low-grade tumors that characteristically have KRAS mutations. Insofar, we do not know of any cases of metastasis, so instead of calling it carcinoma, we call it neoplasm in the WHO. It was left within the chapter of papillary renal cell carcinoma, so that's a little bit confusing, but we're still learning. The consistent GATA3 and L1-CAM positivity and negative Vimentin staining pattern and frequent KRAS mutations are hallmarks of this tumor. There's a high likelihood that papillary renal neoplasm with reverse polarity will be included as a distinct entity in the next edition of the WHO classification. However, the GUPS update suggests that although GATA3 expression and KRAS mutations make this tumor a unique entity, the predominant papillary architecture, documented gains of chromosome 7 and 17, and loss of Y in some reports also argue for the inclusion of this tumor as a subtype of papillary renal cell carcinoma. There are other emerging entities such as biphasic hyalinizing simomatous RCC, biphasic squamoid alveolar RCC, and thyroid-like follicular RCC. Some of them have a specific molecular-driven alteration, for example, NF2 mutations in biphasic hyalinizing simomatous RCC, and EWSR PATZ1 fusions in thyroid follicular-like carcinoma of the kidney. It is anticipated that several of these newly defined tumors will become independent renal cell carcinoma entities in the future WHO classification. So in summary, changes in nomenclature included clear cell papillary renal cell carcinoma to clear cell papillary renal cell tumor, TCEB1 mutated RCC to ELOC mutated RCC, hereditary leiomyomatosis and renal cell carcinoma to FH deficient RCC, and RCC unclassified to RCC NOS. The category renal cell carcinoma unclassified has now been renamed again as renal cell carcinoma not otherwise specified for those tumors that don't really fill a diagnostic criteria for other well-defined entities, either low-grade or high-grade. There are no defined diagnostic criteria for these tumors, and the tumors in the following scenarios may be placed in an unclassified category or renal cell carcinoma NOS. Tumors that show features of greater than one different subtype, low or high-grade unclassified oncocytic eosinophilic neoplasms, or tumors with pure sarcomatoid morphology. Sarcomatoid carcinoma is not recognized as a separate entity. Entirely sarcomatoid tumors have been placed in this group, and these tumors share features with other subtypes with sarcomatoid differentiation. The category of unclassifiable RCC should be reserved for only those renal tumors where all modalities of investigation have been exhausted. So as a group, these tumors carry a mortality rate higher than clear cell RCC. The correct use of this category is really important. The continuous reevaluation of this category in tumors with the emerging molecular markers is critically important for future renal tumor classification. Type 1 or 2 papillary RCC, the subcategorization has been eliminated. A category of other oncocytic tumors, including LOT, eosinophilic vacuolated tumor, and hybrid oncocytic tumor, have now been introduced. Eosinophilic solid and cystic RCC is accepted as a new and independent tumor entity. And lastly, WHO ICP grading now has been validated for clear cell and papillary renal cell tumors, while in previous editions of WHO classification, ISUP histologic grading of renal cell tumor types was recommended specifically for clear cell renal cell carcinoma and papillary RCC, as grading was not validated for the other subtypes of RCC. However, it has been proposed as potentially useful for SDH deficient RCC, mucinous tubular and spindle cell carcinoma, ELOC mutated RCC, TFEB rearranged RCC, and RCC in OS, and FH deficient RCC, including hereditary leiomyomatosis and renal cell carcinoma syndrome associated RCC. Collecting duct carcinoma and SMARCB1 deficient medullary renal SMARCB1 deficient renal medullary carcinoma are considered as inherently aggressive RCCs, irrespective of their histologic grading. The grading can be potentially misleading in tubulocystic RCC, acquired cystic disease associated RCC, eosinophilic solid cystic RCC, and eosinophilic and vacuolated tumor, because despite their high nuclear grade, the overall biologic behavior of these tumors is pretty indolent. Limited data are available on nuclear grading and its correlation with disease outcome in ALK rearranged RCC and RCC and OS, while histologic grading is not clearly applicable or may not be useful in chromophobe RCC and TFE3 rearranged RCC. Clinicians rely on nuclear grade and sarcomatoid differentiation, which is considered a feature of aggressiveness and allows the selection of immune checkpoint inhibitors as the first-line treatment in such cases. Advanced and high-quality IHC and molecular assays have become crucial for accurate cancer diagnosis, prognosis, and treatment response prediction. As there is a growing effort to transform the morphological classification to one based on molecular profiles, many pathologists may encounter difficulties in standardizing an optimal diagnostic algorithm to categorize these renal cell carcinomas. These limitations not only pertain to physical issues, but also to proper availability of diagnostic genetic tests, as well as skilled and trained manpower and resources. Therefore, the value for histomorphology as the first and foremost is diagnostic tool. Okay, switching gears now to prostate. Not too many updates here. Ductal adenocarcinoma is maintained as a separate entity from Asner adenocarcinoma. Pin-like carcinoma has been reclassified as a subtype of Asner rather than ductal adenocarcinoma. And the decision to rename basal cell carcinoma was agreed upon to avoid confusion with the SCID tumor. Treatment-related neuroendocrine carcinoma of the prostate has been described in a separate dedicated chapter because of its high mortality. So a few words and recommendations about intraductal carcinoma of the prostate in the next slide. But first, in the current edition of the WHO classification, the term ductal adenocarcinoma is retained for only those cases with more than 50% ductal morphology and radical prostatectomy, whereas the term adenocarcinoma with ductal features is recommended needle biopsy cases for those lesions exhibiting both pure ductal and mixed ductal and Asner features. There was notation of transitioning ductal adenocarcinoma into a subtype of Asner adenocarcinoma rather than maintaining it as a separate entity. This discussion was steered by the fact that most ductal adenocarcinoma cases usually coexist with Asner adenocarcinoma, as well as the fact that they both of these entities were clonally related due to shared ERG rearrangements with only occasional studies indicating a discordant molecular origin. Only future studies and data will really determine the further integration of both of these lesions. The entity prostatic intraepithelial neoplasia, like adenocarcinoma, has been included under acinar adenocarcinoma in the current edition because of its behavior and recently described genetic changes, which are different from those of ductal adenocarcinoma. So pin-like carcinoma has been described morphologically by large discrete glands, crowded and often cystically dilated, lined by flat or tufted epithelium of tall columnar cells, lacking the papillary or cribriform architecture characteristic of ductal adenocarcinoma. Pin-like carcinoma has been reported to have a more favorable prognosis, similar to low-grade acinar carcinoma, and has thus been assigned a Gleason score of 6 only. Again, as I previously mentioned, the decision to rename basal cell carcinoma to adenoid cystic or basal cell carcinoma of the prostate was agreed upon to avoid confusion with the skin tumor. The term adenoid cystic is synonymous with the salivary gland neoplasm having cribriform morphology, and prostate basal cell carcinoma can show a cribriform anastomosing cords and tubules, as well as solid nested appearance with or without central necrosis. As aligned with the entire organization of the 5th edition series, metastatic, hematolymphoid, mesenchymal neuroendocrine, and genetic syndrome-related tumors are each discussed in separate chapters across various GU organs. The only exception are mesenchymal tumors that are thought to originate from the prostate stromal cell proper, and treatment-related neuroendocrine prostatic carcinoma, given their distinct features at the biological and clinical level. Treatment-related neuroendocrine carcinomas of the prostate continue to present management challenges and have a heavy mortality toll in castration-resistant prostate cancer. In addition, the ISUP working group recommends specific criteria for the usage of neuroendocrine markers in prostate cancer, which include 1, for clinically localized prostate cancer, immunostaining for neuroendocrine markers like synaptophysin, chromogranin, or CD56 are not really recommended unless there are clear morphologic features of neuroendocrine differentiation. 2, given its clinical implications, the term neuroendocrine differentiation is best reserved for high-grade cancers and not usual type adenocarcinoma with well-differentiated neuroendocrine tumors. And lastly, 3, advanced metastatic castrate-resistant prostate cancer may manifest a range of morphologic features of neuroendocrine differentiation, and combination of molecular evaluation of morphologic features may be required in future definitions of castrate-resistant prostate cancer, guided by biomarker-driven clinical trials. Okay, and now intraductal carcinoma of the prostate. Intraductal carcinoma of the prostate, described entity in 2016 WHO classification. It's an expansile proliferation in neoplastic cells within the native ducts, and acini predominantly a solid or dense cribriform growth involving greater than 50% of the glandular lumen. Chemotonecrosis is strongly associated with intraductal carcinoma of the prostate and may be used as a diagnostic criterion. The inclusion of loose cribriform and/or micropapillary architecture as intraductal carcinoma of the prostate is still a matter of debate, and whether cytologic atypia is required is also controversial. The most important differential diagnosis from the morphological standpoint, particularly in needle biopsies, include high-grade prostatic intraepithelial neoplasia and cribriform Gleason pattern 4 acinar adenocarcinoma. For atypical lesions that do not meet the criterion of intraductal carcinoma of the prostate, the term atypical intraductal proliferation is preferred. The lesions which have been previously described as cribriform patterns of high-grade PIN are currently included in the atypical intraductal proliferation category. Basal cell markers are recommended for prostate biopsies displaying isolated intraductal carcinoma of the prostate without concomitant invasive prostate cancer. And prostate-specific and urothelial markers are also mandatory in solid patterns of intraductal carcinoma of the prostate, which can mimic intraductal spread of urothelial carcinoma or metastasis from other organ sites. Ductal prostatic adenocarcinoma can also show in an intraductal fashion. So it's recommended that intraductal carcinoma of the prostate should not be assigned a Gleason grade, and reporting of an isolated intraductal carcinoma of the prostate and needle biopsy should be followed by a comment stating that the therapy may be warranted considering its usual association with a high-grade and high-volume prostate carcinoma. However, whether the need to include the architecture intraductal carcinoma into the current Gleason grading system and Gleason grade group is still a matter of further investigation, because there's not a lot of, there's insufficient data. Okay, now on to bladder. Special attention has been given to grading heterogeneous lesions, inverted tumors, substaging in new molecular taxonomy based on a 4-gene panel consisting of GATA3, keratin 20, keratin 14, and keratin 5. Flat urothelial hyperplasia is now considered benign. Papillary urothelial hyperplasia or urothelial proliferation with undetermined malignant potential is no longer recognized as a distinct entity in the current edition. Urachal carcinomas have been updated in their molecular profiling, and new carcinomas of the urethra have been newly included in this current edition. So the morphologic grading system of papillary neoplasms into urothelial papillomas, papillary urothelial neoplasm of low malignant potential, low-grade urothelial carcinoma, and high-grade urothelial carcinoma is still retained. 2 benign entities, namely urothelial papilloma and inverted papilloma, have been included in the non-invasive urothelial neoplasm section with their individual subchapters. Although some pathologists prefer to report papillary urothelial neoplasm of low malignant potential as a stage PTA lesion, the current WHO does not recommend the name carcinoma with this entity, as these lesions have lower rates of recurrence and progression when compared with actual non-invasive low-grade carcinomas. The issue of intratumoral heterogeneity and lack of clearly delineated criteria continues to be one of the major diagnostic challenges, as tumor heterogeneity and grade is noted in many as 1/3 of non-invasive papillary urothelial carcinomas, and the presence of high-grade component influences the outcome. The proposed criteria is of reporting papillary tumors as high-grade. So if the high-grade component represents 15% of the tumor, conversely, if the high-grade component is less than 5%, the report should be stated as low-grade with less than 5% high-grade component. The new WHO does not include the terms hyperplasia or urothelial proliferation of unknown malignant potential described previously in the 3rd and 4th editions. The potential use of the term urothelial dysplasia is really a matter of debate and continues to be lack of agreement and poor reproducibility in the diagnosis of urothelial dysplasia. The definition of dysplasia is not synonymous to intraepithelial neoplasia and is defined as a lesion that's considered to be pre-neoplastic in nature, but falls short of the diagnosis of carcinoma in situ. In patients with a prior history of urothelial carcinoma associated with changes that could have been induced by prior instrumentation, intravesical therapy, a diagnosis of dysplasia can be quite challenging. The previously described lesions designated as papillary urothelial hyperplasia or urothelial proliferation with undetermined malignant potential are no longer recognized as unique entities in the current edition. There have been attempts to refine the definition of dysplasia as a lesion thought to be clearly neoplastic, but with morphologic features did not quite make the threshold for urothelial carcinoma. And that of urothelial atypia of unknown significance as a descriptive term in case of diagnostic uncertainty of a lesion of whether it's clearly reactive or neoplastic. Flat urothelial hyperplasia is observed in a variety of conditions and is considered to be a commonly regarded precursor. According to the current edition, in the presence of early tufting without a fibrovascular core, urothelial thickening might be considered to be shoulder lesion of a non-invasive tumor in patients with papillary tumors and chromosome alterations, playing a role in tumor suppressor genes, and have been described in this context. It suggested that these flat lesions be named atypical urothelial proliferation, with the additional qualifier of flat or tinted if some papillary formations without a fibrovascular core are present. This dual pathway model for bladder carcinogenesis combines molecular, genetic, and pathologic data. Additional support to the molecular and dual pathway in bladder cancer includes FGFR3 mutations and alterations as a common feature of the genetically stable low-grade papillary carcinomas, and the identification of TP53 mutations as the hallmark molecular genetic alteration of the genetically unstable high-grade urothelial carcinoma. So two main pathways of bladder cancer established are non-muscle invasive and muscle invasive carcinoma. Non-muscle invasive carcinoma comprises up to 80% of the urothelial cancers and includes low and high-grade papillary non-invasive and superficially invasive tumors, so PTA and PT1. They're prognostically favorable, stable in terms of molecular genetics, and with urothelial hyperplasia as pre-malignant lesion. And advanced muscle invasive urothelial carcinoma is prognostically unfavorable, unstable in terms of molecular genetics, and usually develop from flat urothelial lesions, that is carcinoma in situ, and express either papillary or non-papillary phenotype. The morphologic classification of urothelial cancer is suggested to be replaced with a new molecular taxonomy. This is a schematic of the evolving molecular classification of urothelial carcinoma of the bladder. The discovery of molecular pathways in urothelial carcinogenesis may allow for a better classification, prognosis, and development for novel non-invasive detection and surveillance strategies, as well as selection of effective therapeutic targets in a neoadjuvant to adjuvant setting. However, owing to lack of sufficient data, there has been a delay in consistent application of these prognostic and predictive markers in routine pathology and clinical use. More recently, Lopez Beltran and colleagues evaluated molecular taxonomy of urothelial carcinoma as luminal, basal, and null or double negative categories with regard to a 4-gene expression panel comprising GATA3, CK20, CK14, and CK5. These 3 molecular categories were corroborated in terms of overall cancer-specific survival, as well as PD-L1 expression. The luminal subtype denoted a more favorable cancer-specific survival in contrast to the basal and null subtypes. Additionally, a high PD-L1 expression was mostly seen in basal and null subtypes and in carcinomas with variant histology. And just briefly, urachal carcinomas have been updated in their molecular profiling to aid in the differential diagnosis. Non-cystic urachal adenocarcinomas show a distinct molecular phenotype that is more similar to colorectal adenocarcinomas than urothelial carcinoma of the bladder. Urachal adenocarcinoma often harbor TP53 mutations with activation signaling pathways and molecular alterations mostly in RAS, KRAS more than NRAS genes, followed by PIK3CA, BRAF, and NF1 genes. Microsatellite instability, DNA mismatch repair deficiency, and TERT promoter and POLE mutations are less frequent in urachal adenocarcinomas, and they are associated with higher tumor mutation burden. Okay, just a couple of slides on testis. The 2016 modifications of testicular tumors continues to be retained with the use of the term germ cell neoplasia in situ for the range of pre-neoplastic lesions, as well as a classification of testicular tumors derived from germ cell neoplasia in situ or non-germ cell neoplasia in situ derived germ cell tumors, such as some teratomas and spermatocytic tumors. The summary of changes include changes in nomenclature from primitive neuroectodermal tumor to embryonic type neuroectodermal tumor and testicular carcinoid to testicular neuroendocrine tumor. Neuroectodermal differentiation is frequently encountered in post-pubertal type teratomas, and primitive neuroectodermal tumors, or PNET, may arise in a secondary somatic type malignancy in non-seminomatous germ cell tumors. In keeping with the 5th edition of the WHO classification of CNS tumors, the term PNET has been substituted with embryonic type neuroectodermal tumor to circumvent the ill-defined nature of the former term and to separate these tumors from Ewing sarcoma. Similarly, primitive ectoderm noted frequently as a component in postpubertal teratomas, has been replaced by embryonic type neuroectoderm. Seminoma is included in the germinoma family of tumors, leading to a more unified classification since these tumors share almost identical morphology, molecular, and immunoprofile. Gonadoblastoma is included under the non-invasive lesions derived from germ cell neoplasia-derived germ cell tumors. Gonadoblastoma is a mixed sex cord stromal tumor, often described as occurring in dysgenetic gonads, but also has been added to the non-invasive lesions derived from germ cell neoplasia in situ. Many variants of gonadoblastoma, as well as cases of mixed germ cell or sex cord tumors, have been recently described. However, owing to the unusual and uncertain nature of these tumors and lack of sufficient publications, their inclusion in the formal classification is still pending. The 5th edition WHO has defined the following two entities in sex cord stromal tumors of the testis: signet ring stromal tumor and myoid gonadal stromal tumor. Most entities have distinct morphologic and immunoprofiles different from other sex cord stromals, so it thus warrants an inclusion as separate entities. In the current edition, another important change is the inclusion of sertoliform cystadenoma under Sertoli cell tumors. I'll share a case in the upcoming slides. And although this tumor is exclusively located in the reedy testis tubules, the rationale behind classification under sex cord stromal tumor is the close histologic and IHC similarities among these tumors. Well-differentiated papillary mesothelial tumor has now been defined as a testicular adnexal tumor type with a favorable prognosis. This is a solitary papillary neoplasm lined by a single row of cuboidal cells with bland nuclear features. Positivity for mesothelial markers, retained BAP1 expression in the absence of homozygous deletion for CDKN2A and BRAF V600E mutation. Next, intratubular large cell hyalinizing Sertoli cell neoplasm or tumor. Either terminology is really accepted. Historically, sex cord stromal tumor with annular tubules, but this is no longer recommended. And I'll share a case of this in the next few slides also. This is exclusively seen in patients with Peutz-Jeghers syndrome and can be found in the chapter on genetic tumor syndromes. While large cell calcifying Sertoli cell tumor is seen both sporadically as well as in the setting of Carney complex, it's included in both the sections on sex cord tumors as well as genetic tumor syndromes. The 5th edition WHO also further separates mixed and undifferentiated sex cord stromal tumors into separate categories of mixed sex cord stromal tumor and sex cord stromal tumor in OS as the individual components of Sertoli cell lytic and granulosa cell components are readily recognizable in the former entity, whereas in the latter, they're not morphologically clear. The clinical behavior of the testicular sex cord stromal tumors is relatively unpredictable, with the occurrence of metastasis in relatively bland tumors resulting in adverse outcomes and death. Owing to the lack of effective chemoradiation treatment options in sex cord stromal tumors, several histopathologic criteria, including tumor size, necrosis, nuclear atypia, LVI, invasive or infiltrative margins, and mitotic count have been proposed as predictors of aggressive clinical behavior. The use of high power fields for mitotic count has been removed in the 5th edition and replaced by square millimeters due to differences in field diameters from different manufacturers. Further investigation is really needed to establish accurate risk stratification schemes based on these morphologic characteristics, including mitotic count using specific field diameter. Again, so sertoliform cystadenoma is not a common lesion that will be encountered, but here you can see the tumor involves a cystically dilated reedy testis. Cords and tubules of tumor are growing in the reedy testis. Classic morphology shows well-formed tubules with some areas showing well-formed and others more ill-defined lumina. And here in the bottom right, the tumor at the periphery is shown projecting into the reedy lumen. And here's an example of intratubular large cell hyalinizing Sertoli cell neoplasia. This case was shared with me by one of my colleagues from PedsPath, where the patient had bilateral microlithiasis and underwent testis biopsy. There are several distinct clusters of expanded seminiferous tubules with thickened and internalized peritubular basement membranes. And of note is the extension of thickened peritubular basement membrane in the lumen. In this cluster of affected tubules, there's also presence of dystrophic calcifications. Okay, and to finish up with penis and scrotum, a lot to take in, but I'll just summarize. The current model of classifying tumors of the penis and scrotum essentially follows the previous editions, further stratifying the lesions into HPV-dependent and HPV-independent tumors because of its prognostic implications. Evaluation of block type P16 IHC is a practical method in cases of ambiguous morphology or where molecular studies are not available. In cases where the distinction is not possible, a designation of squamous cell carcinoma NOS is considered perfectly acceptable. It's also encouraged to report and quantify subtypes and provide percentages in case of mixed tumors. So although scrotal malignancies have not been a prime subject in the prior classifications owing to, the fact that they're rare, the current edition has described scrotal cancers in the same classification as that of penile carcinomas based on their association with HPV status. Here again, summary of the changes between the 4th and 5th WHO classifications, just a different way of looking at it, if this is easier to take in. So changes in nomenclature includes Paget disease to extramammary Paget disease, and current recommendation of reporting tumors as HPV associated or HPV independent, along with their histologic subtype. And again, it's encouraged to report and quantify subtypes and provide percentages in cases of mixed tumors. Besides the histologic subtype and HPV associated, the pathologic stage continues to be the most important prognostic factor for penile squamous cell carcinoma, and the 3-tier grading scheme introduced by WHO ISUP based on the presence of differentiation, pleomorphism, and keratin production is still important. So in conclusion, all classifications, again, are dynamic and continuously evolving, a very imperfect representation, reflecting the current state of understanding in a particular field at a particular time, as well as the current interpretations based on what we have in available data. The current WHO 5th edition, like its prior editions, should be seen as an evolving work in progress and as a progressing stage in the advancement of urinary system and male genital organ tumor classification. The current edition is attempted to establish and usher in new knowledge into the existing classification systems by including newly recognized entities, phasing out seemingly outdated tumor types, and integrating the molecular taxonomy. It's hoped that such changes provide practical guidance to the surgical pathologists and specialists in GU pathology, and that such progress would only eventually improve risk stratification and treatment selection that will have an impact on clinical outcome. There's been immense progress and innovations in the field of cancer immunology, which has unveiled many complexly evolving mechanisms regulating cellular immune responses. These advances have led to the successful targeting of immune checkpoints while attempting to enhance anti-tumor T-cell response. Immunotherapy is now among the first-line treatment for multiple cancer types, including urologic malignancies. In addition to companion diagnostic kit-based PD-L1 IHC assays, biomarkers, including tumor mutational burden, mismatch repair deficiency, microsatellite instability, and others are being evaluated in various clinical trials with promising results. Inclusion of immune checkpoint molecules and their blockers will be of immense importance in, I think, the future editions. This is an all-in-one slide summarizing the changes between the 4th and 5th WHO classification that were discussed today. Again, emphasis on molecularly defined tumor entities as well as genetic tumor syndromes, such as molecularly defined renal tumor subtypes and molecular classification of urothelial carcinomas. Major nomenclature changes included replacement of variants of major nomenclature changes include replacement of the term variants by the term subtypes, So clear cell papillary renal cell carcinoma, again, to renal cell papillary tumor, TCEB1 mutated RCC to ELOT mutated RCC, hereditary leiomyomatosis and RCC to FH deficient RCC, RCC unclassified to RCC NOS. Again, primitive neuroectodermal tumor to embryonic type neuroectodermal tumor, testicular carcinoid to testicular neuroendocrine tumor, Paget disease to extramammary Paget disease, and basal cell carcinoma of the prostate to adenoid cystic basal cell carcinoma of the prostate. I won't belabor this slide, but to me, I thought it was kind of a nice summary slide, just an all-in-one. So probably I think we're getting close to time. So let me, I just want to, again, many thanks to Deanna and Amy for coordinating this event and allowing me the opportunity to speak today. I've included some references, and I can take any questions that you might have.
Thank you very much. Dr. Collins came in last minute, so we appreciate that. Any questions from the audience?
I have one question. Very nice presentation, Katrina. Thank you for sharing with us. Really appreciate it. So you mentioned that seminoma is included in the germinoma family of tumors as a change. So I'm a little bit confused by that, because I thought seminoma was always part of the germinoma family of tumors.
More with regards to, I think they're more subclassifying the GCNS derived versus the non-GCNS derived.
Right, but that happened in 2016, right? Yeah, but that's okay. I mean, it's just a, not really a change, I suppose.
Sure. So more of a comment than a question, or?
Yeah.
Okay.
Yeah. Thank you.
Well, if we have no further questions, once again, I'd like to thank Dr. Collins